Hello everyone. In this talk, I'll be discussing about hypronasal cannula. So hypronasal cannula is basically a type of non-invasive respiratory support which is provided by the nasal prong, which delivers a continuous airway pressure. If we look at the non-invasive ventilatory support, they are broadly divided into two categories. One is constant airway pressure and another one is the variable airway pressure. Variable airway pressures is NIPPV, BiPAP, or nasal high frequency. While in constant airway pressure, there are nasal cannulas and CPAP, whether it's being constant flow CPAP or variable flow CPAP. While nasal cannula includes the low flow cannula as well as high flow cannula. So today we'll be discussing this high flow cannula with the constant airway pressures. So what is high flow cannula? It is also called as the HFNC. So that means it's a heated, humidified high flow nasal cannula. Heated is like how much is to be heated? So here the gas is being heated near body temperature. The gas is humidified up to 100% of relative humidity, and gas has been given with the high flow. So what is high flow is not defined, but flow more than 1 liter, that is for premature, it's between 2 to 8 liter of the flow per minute is considered to be the high flow. And this high flow, which is heated and humidified, is been delivered via nasal cannula. That's a traditional nasal cannula style prong. And that's why it's called the HFNC, or also called the H3FNC. So why do we need H3FNC? Because we all are very well versed with the CPAP, because CPAP also delivers the heated high flow. Like, we set the flow in CPAP around 6 to 8 liters. We use a humidifier in case of CPAP. We hit the gas as well as humidified the gas. Then how does this differ? So CPAP requires intensive monitoring. As we all know, the studies has proven that CPAP leads to nasal trauma in 40% of the cases. And again, the device is bulky. It is a bit uncomfortable compared to the HFNC for handling. So how does this HFNC differs than the CPAP? HFNC has only inspiratory limb, and this kind of a cannula attached with the inspiratory limb, so which is very comfortable against the CPAP, which has an expiratory limb, which is dipped into the water to generate the PEEP. And how much it has been dipped, the generation of PEEP depends upon the same. So if there is a no expiratory limb in HFNC, then let's see that how HFNC works. So there are various mechanisms for HFNC to help in work of breathing and helping in the respiratory support, one of which being the washing out of the CO2 from the anatomical dead space. What is dead space? The space starting from the nasal cavity, nasopharynx up to the trachea, which is the space which doesn't take part in the gas exchange. It's called the anatomical dead space. So when we exhale the breathe out, at that time our nasopharynx is being filled with the carbon dioxide rich air. And when we take the second breathe in, at that time, the oxygen rich air mixed with the carbon dioxide rich air and will be delivered to the alveoli. If we see in case of newborn, this anatomical dead space is almost 3 times greater than in case of the adult. And that has been filled with the CO2. So giving the high velocity of gas insufflation promotes the CO2 washing out from the nasopharynx. And that is how it will help in washing out of the CO2. Again, when you give the high flow or high velocity of the gas, it will lead to little bit stretching of the airways and decreasing the resistance as the diameter increases. So it decreases the upper airway or inspiratory airway resistance. And this is how it also decreases the work of breathing. So that's how the HFNC helps. The fourth mechanism is heating and humidifying. When we take the breathing, we take the room air, which is around 27 to 28 degree heated. And in our nasal cavity and in our upper airway, it is being heated and humidified, heated up to body temperature, and it is also being humidified. And this process requires energy. When we are giving this air, which is cold, around this gas is around 4 to 5 degrees, and this is without moisture. Then, if we give this high velocity cool gas, then it leads to moisture and heat loss. And this results in thickened secretion and impaired clearance, drying of the nasal passages, ultimately leading to mucosal injury. It ultimately slows down or stops the mucociliary clearance. That is how reduce the airway patency and compliance. There will be a compromised airway defense. It also leads to the patient discomfort, ultimately infection, bronchospasm, everything. So that is why never ever give the high flow without humidification. So whenever you are using high flow rates, always heating and humidification. So this is being preheated and humidified. It decreases the gas conditioning, and hence it decreases the metabolic need of the body. It also increases the FRC. That is also one of the mechanisms. So how can it produce a PEEP? Yes, it do produce a PEEP. As we all know, whenever there is a flow is passing through a tube and any resistance is applied, there will be a generation of the PEEP. But in case of HFNC, the pressure is variable, and this pressure again depends upon the flow and resistance. So flow, which is being used in relation to the size of the body, and resistance, which is being applied, it depends upon the size of the prong in relation to the NES. And again, third thing is leak in the system. Let's see in this diagram how the increase in the flow would lead to increase in the PEEP. This flow of around 2 liters generate the PEEP of around 3, and this flow of around 6 would generate the PEEP of somewhere around 4.5. With the increasing flow, the generation of PEEP increasing, at the same time, the variation in the pressure also increases. Like here, the variation is somewhere around 0.5 to 1, while here the variation is more, the fluctuation in the pressure is more. So with increase in the flow, the fluctuation in the pressure is more, and pressure is variable in case of high flow nasal cannula. And this is the second diagram, which depicts the size of the nasal prong in relation to the NES diameter of 10 millimeter and 9 millimeter, and we can see that how the diameter increasing in relation of the NES, and again the flow increases. How the pressure increases. Again in this, when the diameter of nasal prong increases and flow increases, the generation of PEEP also increases. So there is a generation of PEEP, but it is variable. Let's see the case scenario. 32-week 1.3 kg baby delivered via LSCS, and there was a respiratory distress. This SS score was 4, and X-ray was showing mild HMD. The child was hemodynamically stable. So what kind of a respiratory support will you start with this baby? So let's see that can we start HFNC for this child. So if we look at the indication for HFNC and look at the evidence for the same, first indication is post-extubation, and that is the most common indication and mostly proven indications. This is the Cochrane database from 2016, and that shows that HFNC has a similar rates of efficacy for preventing treatment failure, death, and CLD compared to other forms of the non-invasive respiratory support. At the same time, it decreases the rate of pneumothorax. There is a small reduction in rate of nasal trauma too. But most evidence are available in this systemic review is for HFNC as a post-extubation support, and that has been proven. The second indication is in case of respiratory distress syndrome as a primary support. So let's see what are the evidence about the same. So this is a very good article. This is a very good meta-analysis published in 2019 by Mandy et al. And where they have compared the high flow versus CPAP, and they have included the 5 major important studies, and here it favors the CPAP. So treatment failure is more with the HFNC, and there should be one should shift to the CPAP. Start with the CPAP. And the most important study, that is the hipster trial. Let's see that is the same that Robertson et al. Study. And this hipster trial tells that it favors, primary outcome favors the CPAP. The CPAP is better than the HFNC, but When the baby is bigger, so 80% of the infants more than 32 weeker can be managed only with the nasal high flow. And there were two more Indian studies which were stopped because of the obvious beneficial effect of CPAP over the high flow. But there they found that the high flow was failed mainly in those who are premature babies, more premature, that is less than 32 weeker, and who has more distress, that is Silverman Anderson score of less than more than 5. So for bigger babies, definitely one may try with the high flow as a primary support, but not with the premature babies. The third indication is for slow weaning from the CPAP. When you are weaning from the CPAP and CPAP is required for the longer time and it is not possible to wean, one may try with switching the child to high flow. And there are a couple of studies which has shown that high flow can decrease the duration of hospital stay and need for the oxygen support, but the results are conflicting. So one can consider switching over to high flow for those who require CPAP for longer duration. And whenever there is a nasal injury with the CPAP, and if it's difficult, at that time one may try with the high flow. High flow also works with the apnea of prematurity. There is one or two studies and which has shown beneficial effect. But its use as a primary mode still under vigorous clinical thresholds, especially for the extreme premature babies. And where we cannot use the high flow, when there is a frequent apnea, definitely you need to increase the support, like either in the form of CPAP or an IPPV. When child is hemodynamically unstable, and when there is an upper airway abnormality, and when it is difficult to give the high flow. So when we convince that the high flow is to be given as a post-extubation or as a primary support for bigger babies, let's see that how the high flow can be attached. And this is the video which shows that how the high flow can be attached. There's only inspiratory limb where you attach the nasal cannula. And when you select the size of nasal cannula, you should be more cautious that it should occupy less than 50% of the nest. Should not occupy more than 50%. That is what you should remember. So start with 5 liter of the flow and 50% of FiO2 with 50% of the leak at nest. So select, remember the rule of 5-3-4-H3. So that is 5 liter of the flow, 50% of FiO2 and 50% of the leak. And when you select the size of the cannula, there are different companies have cannulas, high flow cannulas available, but the red one this is the table for the optiflow cannula. The red one is meant for the premature babies. Then yellow is for neonatal size and violet is for infant size. Let's discuss the case scenario again. In this case, we decided to start with the HFNC, and we started the HFNC with 50% FiO2 and flow of 5 liters. 2 hours later, baby need the FiO2 of 60%. Child was otherwise hemodynamically stable. So what shall we do? Shall we shift the support or can we do anything else? We had started with the flow of 5, so we can increase the flow. When shall we increase the flow? When FiO2 requirement increased to 10%, if there is a worsening distress. If you get the X-ray and if you see that there is a lesser volume in the X-ray, that is also the time where you can think about increasing the flow. And if there is an increasing CO2, ventilation is the issue, you may try increasing the flow. Increase the flow by 1 liter per minute, but go up to maximum of 8 liter. Don't go more than 8 liter per minute and FiO2 of around 60%. Otherwise, you have to shift the child to other modality. Once your child got stabilized on high flow, then how can you wean the child from the high flow? So if baby is stable for 12 to 24 hours, you may start weaning the child. While you're weaning, first wean from the FiO2, reach up to 30%, then start weaning the flow 1 liter per minute every 12 hours. And then if flow reaches to 3 liter per minute, then you may think about or you should discontinue about the H3FNC. But during weaning, constantly monitor the patient, and whenever you feel that the child is deteriorating, then you should shift back to the previous support. When you consider failure of HFNC, when there is a need of FiO2, persistently need of FiO2 is high, that is more than 60%. If there is a increased work of breathing, if there is a respiratory acidosis, that is pH of more than 7.25 and CO2 of more than 60, in spite of giving the 8 liter of flow and proper oxygenation of 60%. In this case, and if there is a recurrent apnea, that is considered to be the failure of HFNC, and one should increase the respiratory support. So take home message here is the pressure generated with the H3FC is variable, H3FNC is variable. You can neither set the pressure or can measure the pressure. Remember while setting up of the high flow cannula, the rule of 5-3 for H3. Bronch should occupy less than 50% of the diameter. There should be a leakage because there is no expiratory limb, and expiration is going to happen through mouth as well as around the bronchs from the nostrils. It has proved that HFNC has a proven role for post-extubations from mechanical ventilations, but as a primary mode, it should be avoided for extreme premature babies. Those who are of more than 30 to 32 weeks, as a primary modality, one can try with the HFNC. It can be also used as a weaning from the CPAP if CPAP is required for the prolonged duration. Thank you.